Welcome to Pharma. Opioid withdrawal syndrome is a life-threatening condition resulting from opioid dependence. There are two forms of opioid dependence, psychological and physical. Psychological dependence is a form of addiction. To simply explain it, it develops when a patient gets to have the substance to be able to function or engage in a work-related tasks or to be relaxed. Patients with psychological dependence develop a strong relationship with the substance that's making them experience anxiety and anhedonia when trying to stop taking the drug. Opioids also can cause severe addiction, which involve craving and compulsive seeking or taking of substances. For example, illicit drug use or street drug like heroin. Physical dependence is developed when a patient is exposed to a medication for a prolonged period of time. The body physically neuroadapt to the presence of chemical. No craving and compulsive behavior are involved. The patients only experience physical symptoms when trying to suddenly stop with the medications. Patients who are taking opioids develop tolerance within the first doses. It occurs when the receptors become less sensitive to opioids when the same dose was given. The patients may end up needing larger doses to get the same first effect. Withdrawal symptoms manifest when the patient sees opioid abruptly, especially in those who have been on opioid for a prolonged period of time. Slowing is important to reduce the risk of withdrawal symptoms. Both naloxone, an opioid antagonist, and buprenorphine, partial opioid agonist, can precipitate withdrawal symptoms as well. Mechanism of opioid withdrawal. Opioid receptors are present in high amount and concentrated in central nervous system, especially in locus coeruleus. They also found in the peripheral neurons, but in lesser extent. Locus coeruleus is the primary site of noradrenaline production in the brain. Opioid abstinence can cause superactivation of adenylate cyclase pathways, which in turn lead to overrelease of noradrenaline in locus coeruleus that has been thought to play an important role in opioid withdrawal symptoms. According to the DSM-5 criteria of opioid withdrawal symptoms, patients may experience autonomic hyperactivity, such as tachycardia, tachypnea, hyperflexia, hypertension, hyperthermia, and sweating. Other symptoms include lacrimation, rhinorrhea, piloerection, which is also called goose flush, myalgia, diarrhea, nausea, vomiting, pupillary dilation, photophobia, insomnia, yawing, and finally, dysphoric mood. Please remember that tolerance usually diminishes after withdrawal, so there is high risk of overdose if used on smaller doses than used prior withdrawal. For the management of opioid withdrawal, buprenorphine is a partial opioid agonist with ceiling effect. Should be started at least 6 to 8 hours after ceasing short-acting opioid like heroin, and when signs of withdrawal become evident. Delay starting buprenorphine because it can precipitate withdrawal symptoms in the first dose. The dose of buprenorphine should be titrated according to withdrawal severity. The initial dose is 4 to 8 milligrams sublingually as a single dose. The dose can be increased up to 12 milligrams on the third day as a single dose. The dose should be reduced over the following 2 to 5 days. In the inpatient setting, however, lower doses should be used due to extra benefit of psychosocial interventions. For symptoms control medications, paracetamol and NSAIDs for the management of musculoskeletal pain, metoclopramide for the management of nausea and vomiting, diazepam for the management of anxiety and agitation, loperamide for the management of diarrhea, and finally clonidine for the management of autonomic hyperactivity and insomnia.